I'm Dr. Rios Fabian, and this is The Art of Medicine. This discussion in the Ophthalmology lecture series covers hyphema. Hyphema is defined as the accumulation of red blood cells in the anterior chamber of the eye. It most commonly occurs due to a high-velocity traumatic impact to the eye, with resulting disruption of blood vessels in the iris or ciliary body. Red blood cells, clotted blood, and fibrin may collect in the eye's drainage angle. This physically blocks the trabecular meshwork, preventing the natural outflow of aqueous humor from the eye. This in turn may cause an elevation in intraocular pressure. Hyphema is a potentially vision-threatening medical emergency, and all cases require prompt assessment by an ophthalmologist. The appearance of hyphema may vary by how much blood is present in the anterior chamber. When the term hyphema is used, this typically refers to a macrohyphema, meaning that blood is grossly visible in the anterior chamber. Blood is visible in the inferior portion of the chamber, with red blood cells settling at the dependent aspect of the eye when the patient is upright due to the effect of gravity. A microhyphema refers to dispersed red blood cells that are present in the anterior chamber without layering or a visible fluid level, which is visible on slit lamp exam but not to the naked eye. Hyphema has multiple potential causes, the most common of which is a traumatic injury to the eye. This may include blunt force or penetrating injuries. Traumatic hyphema is most common between ages 10 to 20 and is 3 to 5 times more likely to occur in males. The most common specific causes of injury vary by age group, with sports-related injuries being more common in children. Some of the most common sports include basketball, baseball, hockey, and soccer. Hyphema may also occur due to accidents related to paintball and airsoft guns, impact from vehicle airbags, firearm or shrapnel injuries, foreign bodies from high-speed power tools like drills and saws, and trauma related to violent assaults. Hyphema may also have non-traumatic or spontaneous causes, which occur in those who are prone to bleeding without significant external force. Certain conditions, such as poorly controlled diabetes and ischemia, can cause abnormal, fragile blood vessels to grow on the surface of the iris, a condition known as rubeosis iritis. These abnormal vessels are more prone to bleeding. Intraocular tumors, such as retinoblastoma and iris melanoma, are often highly vascularized and are capable of bleeding as well. Infectious or inflammatory conditions of the eye, such as keratitis or uveitis, may cause neovascularization. Juvenile xanthogranuloma, which is the most common type of non-Langerhans cell histiocytosis, presents with firm papules or nodules of the head, neck, and upper trunk. In rare cases, it may affect the eyes with highly vascularized nodules that may spontaneously bleed. Other potential non-traumatic and spontaneous causes include blood dyscrasias, clotting disorders, and cases associated with antiplatelet or anticoagulant medications. These specific causes confer a higher risk of complications, including elevated intraocular pressure, optic atrophy, glaucoma, secondary hemorrhage, and permanent vision loss. Blood dyscrasias and clotting disorders that may be associated with a spontaneous hyphema include leukemia, hemophilia, and von Willebrand disease. Antiplatelet and anticoagulant medications include aspirin and warfarin, respectively. Sickle hemoglobinopathy, which may include sickle cell disease or sickle cell trait, is one of the most clinically relevant conditions associated with hyphema and warrants special attention due to a higher risk of potential complications. In sickle hemoglobinopathy, red blood cell sickling is more likely to occur in the trabecular meshwork due to the relative hypoxia and acidic pH of the anterior chamber. These sickle cells can block the outflow of aqueous humor, resulting in an increase in intraocular pressure. In addition, intravascular sickling may lead to vaso-occlusive events, such as central retinal artery occlusion and ischemic optic neuropathy, even at mildly elevated intraocular pressures. These patients therefore require closer observation and may have a lower threshold for surgical intervention. Hyphema may also be iatrogenic, occurring intraoperatively or postoperatively in procedures involving the manipulation of highly vascularized tissue. It is rare in routine elective cases, but patients with abnormal underlying vasculature are at higher risk. This may occur with intraocular surgeries, such as angle-based glaucoma surgeries, vitrectomies, or insertion of intraocular lenses. It may also occur in the setting of laser procedures, such as laser peripheral iridotomy. Implant complications include uveitis glaucoma hyphema syndrome, which is caused by mechanical shaping due to malpositioning of an intraocular lens. This condition presents with the triad of uveitis, increased intraocular pressure, and microhyphema or recurrent bleeding. Hyphemas are graded according to the amount of blood filling the anterior chamber, with higher grades correlating with a higher risk of complications, such as increased intraocular pressure or rebleeding. The listed percentage is the best prognosis for 20/50 vision or better. A grade 0 hyphema is a microhyphema, characterized by scattered red blood cells only visible on slit lamp exam, and a best favorable prognosis of 90%. A grade 1 hyphema is characterized by blood filling less than 1/3 of the anterior chamber and a best favorable prognosis of 90%. A grade 2 hyphema is characterized by blood filling 1/3 to 1/2 of the anterior chamber's volume and a best favorable prognosis of 70%. A grade 3 hyphema is characterized by blood filling more than 1/2 but not the full volume of the anterior chamber and a best favorable prognosis of 50%. A grade 4 hyphema is characterized by blood filling the entire anterior chamber and a best favorable prognosis of 50%. If bright red blood fills the entire anterior chamber, this is called a total hyphema. If dark, clotted blood fills the entire anterior chamber, this is referred to as a black ball or 8-ball hyphema, which carries an increased risk of pupillary block and secondary angle closure. A hyphema typically presents with eye pain, discomfort, blurred or hazy vision, and vision loss in severe cases. Patients may also present with photophobia due to pupillary constriction or contraction of the iris musculature, causing pain. An elevation in intraocular pressure may cause glaucoma or corneal damage and may result in nausea and vomiting. These symptoms may worsen if the patient experiences a rebleed, the incidence of which peaks 2 to 5 days post-injury. Trauma cases presenting with hyphema may be associated with additional injuries, such as corneal abrasion, iridodialysis, which is when the iris tears away from its insertion, lens damage, orbital fracture, lens subluxation or dislocation, retinal tear, retinal hemorrhage, or a vitreous hemorrhage. When obtaining a clinical history, patients should be asked about recent eye trauma, vision changes, foreign body sensations, or increased light sensitivity, history of ocular surgeries, a personal or family history of predisposing conditions, such as blood dyscrasias or clotting disorders, and the use of antiplatelet and anticoagulant medications. If a child presents with hyphema without preceding trauma, consider the possibility of bleeding disorders, ocular tumors, or abuse. All patients presenting with hyphema require a comprehensive eye exam. This includes a gross inspection of the eyelids, lashes, lacrimal ducts, and the cornea, evaluation of visual acuity and extraocular movement, and assessment of pupil size and reactivity. Anisocoria, or unequal pupil sizes, may be present due to torn iris sphincter muscles, resulting in miosis or mydriasis, which is pupil constriction and dilation respectively. Direct and consensual pupillary response may be tested for the presence of a relative afferent pupillary defect. If the patient can't open the affected eye, exposure of the unaffected eye to light will frequently cause pain in the affected eye due to consensual pupillary constriction and associated traumatic iritis. The diagnosis of hyphema is primarily clinical and requires visible blood in the anterior chamber, either by direct observation or a slit lamp exam. Precautions must be taken to prevent further damage. An open globe injury or globe rupture, which is a full thickness wound of the eye, needs to be ruled out prior to pressure-inducing exams, such as eyelid retraction or intraocular pressure measurement by tonometry. It is also important to rule out orbital compartment syndrome, which presents with proptosis, decreased visual acuity, diffuse subconjunctival hemorrhage, and tight eyelids, as this is an indication for immediate surgical decompression. Once these injuries have been excluded, fluorescein staining may be performed to rule out a corneal abrasion, which accompanies many traumatic hyphema cases. Several non-invasive tests may be used during workup. Direct ophthalmoscopy or slit lamp exam may be used to confirm the presence of blood in the anterior chamber and assess for associated injuries. Keep in mind that a total hyphema may obstruct the eye's full anatomy. Tonometry is a diagnostic test that is used for intraocular pressure measurement. Intraocular hypertension, which is defined as a pressure greater than 21 millimeters of mercury, occurs in more than 30% of hyphema cases. Gonioscopy is a test that uses a special lens to examine the eye's drainage. Diagnostic imaging may also be used to further assess for additional injuries. A B scan or brightness scan ultrasound may be used if the posterior view of the eye is obscured. This may be used to assess for lens damage, intraocular foreign bodies, retinal detachment, and choroid hemorrhage. This procedure must be avoided if an open globe injury is suspected due to pressure on the eye. An orbital CT without contrast with 1 to 2 millimeters with axial and coronal cuts may be used if there is a concern for an open globe, intraocular foreign body, or orbital fracture, which may be suggested by a palpable step-off inferior orbital ridge, limited extraocular movement, or significant periocular swelling. If the patient has a known or suspected bleeding dyscrasia, order a CBC, PT, PTT, and INR. If the patient develops a spontaneous hyphema, test for bleeding dyscrasias like hemophilia with a clotting factor assay or mixing studies, as well as for von Willebrand disease with von Willebrand factor antigen, functional assays, factor VIII clotting activity, von Willebrand factor multimers, and platelet aggregation testing. In addition, solubility testing or hemoglobin electrophoresis should be performed in susceptible patients with an uncertain sickle hemoglobin status, such as those of African or Mediterranean descent or a positive family history. Most cases of uncomplicated low-grade hyphema resolve spontaneously with conservative measures. The primary goals of hyphema management are to prevent rebleeding, manage and monitor intraocular pressure, reduce inflammation, and protect the eye from further damage. Regardless of severity, an ophthalmology consultation is needed for all cases. Conservative measures may be used for mild cases. An eye shield may be placed over the injured eye to offer protection from further injury. Of note, placing a patch over the eye is not recommended. An eye shield has holes present so that a patient is able to detect any sudden loss of vision. The eye shield should only be removed for medical assessments and imaging while the patient is recovering. The head of the patient's bed should be elevated to 30 to 45 degrees to promote blood drainage while maintaining proper blood flow to the eye. The patient should sit in a low-lit, quiet, calm environment, and eye movement should be limited for at least 1 week. Patients should also restrict activity with bed rest, limiting exertion, straining, or bending, and reduce reading to limit the stress on the damaged blood vessels. A number of medications may be used to manage symptoms and prevent further progression. Antiemetics such as IV or oral ondansetron may be used to prevent Valsalva or a sudden increase in intraocular pressure due to emesis. Medications for pain control may be used to improve comfort and help facilitate eye exams. Topical anesthetics, such as proparacaine or tetracaine, may be used if no open globe is present. If this is inadequate, oral or IV opioids may be considered. One potential pain regimen includes oral hydrocodone or oxycodone in combination with acetaminophen. If this is still inadequate, IV or subcutaneous morphine or IV fentanyl may be needed. Cycloplegics or dilating eye drops, such as atropine or cyclopentolate, act to relieve ciliary spasm and photophobia, stabilize the iris vessels, limit pupil movement, and decrease the risk of rebleeding. In addition, they dilate the pupil to allow for exam. Cycloplegics are contraindicated in suspected open globe injuries or narrow angle glaucoma. Topical corticosteroids, such as prednisolone acetate and dexamethasone sodium phosphate, act to decrease inflammation from iritis, decrease the risk of synechia, and decrease the risk of rebleeding. They should be used in caution in children, as they can cause a rapid increase in intraocular pressure, as well as cataracts with prolonged use. Topical corticosteroids should not be used if a corneal abrasion is present until it is healed, since they may increase the risk of infection and slow the healing process. Medications used for intraocular pressure control include agents that suppress aqueous flow. These agents should be used with caution, as they may be systemically absorbed. First-line topical agents include beta blockers, like timolol and levobunolol, alpha agonists, like brimonidine and alprazolam, and topical carbonic anhydrase inhibitors, such as dorzolamide and brinzolamide. If these are inadequate, additional options include oral carbonic anhydrase inhibitors, like acetazolamide and methazolamide, or IV mannitol. During the course of medical management, certain medications should be avoided if possible. NSAIDs should be avoided due to their antiplatelet effect. Antiplatelet agents and anticoagulants should be discontinued unless they are medically necessary. Pilocarpine is not recommended, as it constricts the pupil and prevents visualization of the lens and retina. Prostaglandin eye drops like latanoprost may increase the inflammatory response. Carbonic anhydrase inhibitors and mannitol should specifically be avoided in sickle cell disease due to the theoretical risk of sickling due to metabolic acidosis or volume depletion. In sickle cell patients, humidified transcorneal oxygen, delivered at 1 to 3 liters per minute, may be used instead. In certain circumstances, hyphema cases may warrant hospitalization. These include grade 3 or 4 hyphemas, severely elevated intraocular pressure requiring surgical intervention, cases associated with ocular or orbital injuries, those at higher risk of complications, such as sickle hemoglobinopathy and bleeding disorders, young children under the age of 7, as they are at higher risk for amblyopia, as well as patients with a history of noncompliance. Surgical intervention is reserved for severe or refractory cases. One indication is uncontrolled intraocular hypertension, which is defined as a pressure greater than 50 millimeters of mercury for 5 days, greater than 35 for 7 days, or greater than 25 for 24 hours in the setting of sickle hemoglobinopathy. Additional surgical indications include corneal blood staining, a large persistent hyphema, meaning a grade 3 or higher for more than 10 days, and rebleeding cases where vision is threatened. Potential surgical options include anterior chamber washout, clot evacuation, and trabeculectomy. Most patients with hyphema do recover well, but should be monitored for potential complications. Uncontrolled elevations in intraocular pressure may cause irreversible optic nerve damage and permanent vision loss. Rebleeding occurs in less than 5% of cases, peaking 2 to 5 days post-injury. About half of rebleeding cases developed increased intraocular pressure, which predisposes to corneal blood staining, which may require a corneal transplant. Angle recession glaucoma is a type of secondary open-angle glaucoma associated with ocular trauma that develops months to years after the injury, causing elevated intraocular pressure after hyphema resolution. An annual exam is recommended after traumatic cases. Patients should avoid excessive straining following injury and follow up with ophthalmology 24 hours after the initial assessment. They should undergo a daily slit lamp exam for 3 days after the initial trauma to monitor for complications. In addition, patients should be counseled on the use of eyewear during sports or high-risk activities such as airsoft, paintball, or the use of power tools.